A very good afternoon. I'm a fill-in gap co-chair person because probably we are missing somebody here. Really, we have a very learned speaker in front of us. I really don't know, should I talk about him or not because he's one wonderful guy. I've known him personally. He is going to talk about something which even I am interested. And this is, we have the cracking the complexities of the heart failure with preserved ejection fraction through echo. The whole world is talking about heart failure, and we have all kinds of informations. Yesterday we had new molecule which is going to be used in heart failure, and even today we have ARNIs, diuretics, beta blockers, and we all are very confused as to what exactly we should do. I am pretty sure Dr. Shantanu will talk and enlighten us about the heart failure with preserved ejection fraction through echo. Thank you.
Thank you so much. In the field of cardiology now, the biggest challenge has been heart failure. And in that heart failure has been heart failure with preserved ejection fraction. Now, we as physicians are now have been attracted by a lot of innovations in the field of digital world. A lot of AI is coming, both in echo and other fields. And I'm showing you a watch in front of you. This is nothing to do with an echo, but I would like to add that future of cardiology is now going to be in your watch. What I mean to say is that in future, we will be able to do and get information about troponins and proBNP without looking at the blood. So this is preliminary data. I was a part of this small study, and we're doing a big, large multicentric study ongoing, where we have been able to do a spectroscopic, non-invasive assessment of troponin by a transdermal way without giving a prick to the patient. So we have been discussing since yesterday the value of biomarkers, and I thought that in this platform, let me show you that we can still have troponin, and somebody like KK died recently. So if you have a chest pain, you can just press your iWatch for 30 seconds, get a troponin. If it is elevated, go to a doctor, get evaluations. So that is going to the future. This is got published last month in Nature, showing how important we are moving ahead. So HFpEF is a complex process, and I am going to add a few of my understanding with a little bit of my work. So it has been a heterogeneous disorder, and unfortunately one size is not fitting always. And we have been information of assessment of diastolic dysfunction in HFpEF, but many times we have gray zones, and we desperately need some treatment for heart failure with preserved ejection fraction. So these are the causes we are all aware about of CAD, diabetic hypertensive, sleep apnea, metabolic syndrome, who have this entity. A very important paper from Sanjeev Shah showing the structural, functional, and ultrastructural differences in heart failure and HFrEF patients. We have good therapeutic treatment about HFrEF, but HFpEF have subtle changes showing that the volumes may be normal. You do have wall thickness which is higher. The LV masses are more or less similarly there in both the groups. Remodeling mostly seen is concentrating in HFpEF groove, while HFrEF have more predominantly eccentric remodeling. Looking at the end diastolic and unsystolic elastance, there's a big difference in this group, and there is a lot of work looking at the LV and left atrial and systolic and diastolic elastance. Coming to ultrastructural differences, the fibrosis on MR is predominantly interstitial or reactive in HFpEF, while there is a focal or replacement fibrosis. So this gives us insights that there is something which has to be, which we are trying to look at. Now, the concept of cardiac performance has evolved over a period of time from a traditional assessment of cardiac output, stroke volume by the invasive Swan-Ganz, and we do now LV assessment by an echo. But as we said that we are also supplementing with cardiac markers, and we do have to integrate this looking at the contractility by looking at strain, which echo surely gives us, and MRI has now come up with also giving this information. So these guidelines, we are all aware of assessment of diastology, and I just want to briefly add on that we look at the predominant 4 factors of E by E prime, the E prime velocity, the TR velocity, and the LA volume index of more than 34. But it is many times not sufficient, and these guidelines came in 2016, and I'm expecting that in another 1 or 2 years, this will be modified. Now, remember, heart failure with preserved ejection fraction is a spectrum, and you may get different entities, variability depend upon the myocardial involvement in this group. So you can have a predominant cardiac phenotype of HFpEF where it is predominantly the heart is a problem, like an infiltrative cardiomyopathy. But also in the other spectrum, the heart can be involved in an extracardiac causes which raises your filling pressure, like a patient of renal failure, liver failure, or morbid obesity. So the treatment gets changed in this group of spectrum, because always the heart is not the predominant organ which gets involved. And that way, Sanjeev Shah again divided HFpEF into predominantly 4 phenotypes, phenotype 1, 2, and 3. He said that the phenogroup 2 is the most common, which we have been seeing the cardiometabolic group, while the phenotype 3 and the phenotype 1 are different. The phenotype 1 is basically a person who has less BNP or a normal BNP. So if a patient coming with cardiac failure, if the BNP is normal, it doesn't rule out that the patient doesn't have HFpEF, because the myocardial involvement is less, but they have a pretty better prognosis as compared to the phenotype 3. And now what is phenotype 3? They have a predominant more of right ventricle involvement, they have a renal involvement, they can have atrial fibrillation. So it is important for us also to give a diagnosis of HFpEF, and if you can phenotype and give them the information, then it can have a prognosticate importance. Now, as we all know, there are caveats of anti-proBNP, and 30% of this patient of HFpEF can have a normal or low normal anti-proBNP, and this has to be identified. So as I said, that phenotype 1 is the BNP deficiency syndrome, phenotype 2 is the predominantly which we see the cardiometabolic syndrome, and the phenotype 3 is patients who have HFpEF with right ventricular involvement, atrial fibrillation, and renal insufficiency. This group has the worst prognosis, and every patient of HFpEF should be monitored for a right ventricular assessment. Now, yesterday we discussed about heart failure and looking at the strain, and every patient of heart failure, that means every diabetic, every hypertensive, every sleep apnea should get a strain assessment, because the longitudinal strain, which tells you about the subendocardial health, is a marker of the health of the subendocardium, and anything less than -18, -17, -15, that means the heart is getting involved. So this has to be incorporated, and this is one important study where they had looked at the correlation of strains over a spectrum of LV ejection fraction, showing that till there is a lot of interplay between the other fibers also when the heart gets involved. Now, this is another spectrum of phenotyping of heart beyond ejection fraction and beyond strain. So if you have heart failure, if you have LV ejection fraction normal, but there is an entity that you can also have LV ejection fraction normal and strain, global longitudinal strain to be normal. So this this is a classical HFpEF with reduced strain is what we have been talking about. But if you have a preserved GLS, then you start looking at an entity, a sub-entity, a very important entity of isolated left atrial cardiomyopathy, isolated RV cardiomyopathy or RV dysfunction. Now, this is a very important entity where we have started looking at patient presents with HFpEF, everything is normal, strains are normal. Then you start thinking that the left atrial dysfunction is because of primary atrial pathology. Now, coming to a more robust information is correlating whether we can integrate looking at the left atrial strain, and there is a lot of excitement which has come up looking at the left atrial strain, and there has been a last 5 years a correlation, a paper in JACC Imaging, whether the left atrial strain correlates with the GLS. They are looking mostly at the peak atrial left strain. So to give you a brief insight about left atrial strain, whenever you track the left atrium in apical 4-chamber view and apical 2-chamber, you start getting positive values about the baseline, and it gives you 3 kind of strains, which is nothing but the PALS, which is the peak atrial, this should be longitudinal strain, the peak atrial contractile strain, and this is the conduit strain. So I will again show you that this is the reservoir strain, or also called PALS. This is the conduit strain, and the PACS, or the booster strain. This is going to be the future of understanding HFpEF, and lot of excitement has come up looking at this. And the meta-analysis of left atrial strain, which came 5 years back, included 45 studies of more than 30 normals, of which the 38 studies were on a single vendor. And there is a concept called RR gating or PP gating. Predominantly, the suggestion is you should only go for an RR gating. RR is the ECG gating, and the normal values which are given is that the PALS, or the reservoir strain, is more than 38. So we do use this entity now in all our research work, but there is evidence of some heterogeneity also. So we need more information about how the variability goes across the region. But a PLS of more than 38 is now considered as normal. That is important. Now, so a recommendation, one of the papers gave a suggestion that in the patients who are in the gray area, if you can incorporate this PLS and you can confidently say if the PLS is more than 20, it is a normal filling pressure. If it is less than 20, then you are dealing with a left atrial elevated filling pressure. So the concept, what I'm trying to tell is that we should now have information about left atrial strain, focusing on PLS. And this is some work on PLS showing that it has got an prognosticate importance in patients who have atrial fibrillation also. So this was a cutoff which they said were around 31%. So this was an earlier 2017 paper. Coming to few last slides, Dr. Lee Thomas from Australia gave a very nice overview about involving the role of exercise in this spectrum. And she said that as the heart failure ejection with preserved ejection fraction progresses, you can get rest E by E prime, you can get exercise, you can incorporate E by E prime after exercise. But she also has suggested adding up LA strain to LAVI in this group of patients. And again, if you can see that over a period of time, the value of PLS goes below 19 and 20, again focusing on this entity of group. We added something to the literature of PLS in the heart failure group, and this was published last 1 month back, incorporating the role of exercise in this group of patients. And all these patients were made to exercise on a diastolic stress test pro forma, and we concluded that if there is a reduction in the peak atrial strain by 1%, this is associated with a 10-second change in their exercise performance. Now, why exercise is important in heart failure patient? While this is the paper that exercise training has shown to improve diastolic function in heart failure patient. So there are a lot of exercise regimen which are being given to patients, more information that exercise training improves exercise capacity, quality of life, diastolic function in HFpEF patients. So a baseline stress hemodynamics by treadmill or a bicycle test is mandate in all patients whom you are giving an HFpEF. So NT-proBNP levels, echo levels, and a baseline stress level by an exercise is mandate. So the question comes, can you treat it? Can you prevent it? Yes, we have one drug. We have the gliflozins, which are being given for HFpEF patients. But the question is, can it be prevented? Well, we don't know, but maybe a possibility of caloric restriction and exercise is going to be the future of preventing diastolic dysfunction. So this is the assessment of diastology in a fetal neural, I don't know why it is not moving, but the issue is that there is a lot to be learned in the field of HFpEF, and I would also like to invite you to my meeting 2 weeks later to Echo Nagpur to have more insights of cases. Thank you so much.
Thank you so much. We are definitely armed with the theoretical aspects of the heart failure. Now we have another speaker who is going to talk about the breakthrough in the treatment of heart failure with preserved ejection fraction. May I call Dr. Arindam Pandey?